of these AAMS's educational series during this COVID pandemic era. We have gone through several phases of this pandemic. It looks like that initially we started these sessions back in early April. It looked to be that we had reached the peak and we had flattened the curve. However, that appears to either we're in a second peak or that maybe wasn't the case, where there was, we have another spike to deal with. Today was a record-setting day for LA County, and unfortunately, it seems that the cases are going up not only in Los Angeles County, but also in other parts of the state and other parts of our country. Accordingly, it is truly very important that we remain vigilant about staying informed and really using science to protect ourselves and taking the steps to make sure that we are safeguarding the well-being of our families, the well-being of our loved ones, our patients, as well as ourselves. So accordingly, we will be continuing these educational webinar series to make sure that we are sharing the latest information out there that is available in various aspects, by the way, of this pandemic, not just the medical aspects, also practical matters pertaining to telemedicine, practical matters pertaining to employment of healthcare professionals, as well as other business-related issues that pertain to the practice of medicine, taxation, and other issues. A few announcements. Tomorrow night, we'll be continuing with these webinar series, where we will be organizing an event in cooperation, in partnership with the Armenian Bar Association. We will have several speakers that will be addressing the IRS and tax implications as us practitioners, professional practitioners, contend with the various complexities of this pandemic. We will also continue. We have a webinar coming up in the coming weeks that will be dealing with the intricacies of COVID-19 testing, PCR, and antibody testing and other nuances. So that should be a very, very interesting webinar. We also have a few mental health related topics that are on the pipeline, and please be on the lookout for the announcements on these issues. Today, we have with us again Dr. Peter Bretan, who is Bretan, who is the president of the California Medical Association in Sacramento. He joined us last week. However, he's joining us again this week, and he will be delivering his remarks on the second half of this webinar. And, on the first half of our webinar, we have our beloved past president, Dr. Armand Kotikian, who will be addressing our viewership. Dr. Kotikian, as you all know, is a board-certified oral and maxillofacial surgeon in private practice in Glendale. Dr. Kotikian is the former president of the society. He completed his dental school at UCLA and then did a one-year residency in hospital dentistry at Long Beach VA Medical Center. Subsequently, he pursued a residency in oral and maxillofacial surgery. He earned his MD from Wayne State School of Medicine, did 2 years of general surgery, and completed his oral and maxillofacial surgery residency at the University of Michigan in Ann Arbor. He currently is in private practice in Glendale and holds staff privileges at Adventist Health Glendale, Dignity Health, and Providence St. Joe's Medical Center. Dr. Kotikian is also an assistant professor at the University of Southern California in the Department of Oral and Maxillofacial Surgery. Dr. Kotikian specializes in complicated dental implant cases, wisdom tooth extractions, and with office anesthesia. With that, I'd like to invite Dr. Kotikian to please come and take over this platform and please go ahead and enlighten us. Dr. Kotikian will be talking about various ulcerative conditions of the oral cavity. With that, Dr. Kotikian, please go ahead and engage your video and unmute yourself, and please take over this platform.
Thank you, Dr. Sepulveda, for the nice introduction. Good evening, everyone. As Vikan said, my name is Armand Kotikian. I was invited to give this lecture, which is actually for both oral health professionals and physicians alike, because, you know, we both come across these conditions on and off throughout our careers. One thing I should note is I have no financial interest to disclose to anyone. So with that, I'm going to go ahead and get started. Basically, ulcerative conditions, as we all know, is basically defined as basically simple lesion resulting from the loss of the epithelium, the top layer. And you can see it in dental patients, any type of oral lesions that may arise. You have to know how to, you know, when to make the decision if it's something that's, you know, reactive to neoplastic. And I'm going to go over those. The classifications are the following. The most common ones we always think of is always the traumatic ulcerations. You know, they bite something, they have a fractured tooth, or they have a toothpick, or they've traumatized themselves by biting on their tongue. We also have to think about bacterial infections such as syphilis, TB, leprosy, actinomyces, and Noma, which I'll go over. Also rare, but you also see fungal infections, such as deep fungal infections, such in patients who are immune suppressed. And those are the types you see: histo, sporotrichosis, and phycomycosis. As far as classification of ulcerative conditions, the common ones are Aptus ulcers, also known as canker sores, but we also have to think about certain syndromes when these patients come in, such as Behçet's, Reiter's syndrome, erythema multiforme, drug reactions, contact allergies, Wegener's, chronic granulomatous disease, and cyclic neutropenia. As far as neoplasms, the biggest one, which makes up 90% of neoplasms in the oral cavity, is squamous cell carcinoma. But we can also see lymphoma in the oral cavity as well. So the way I like to do these lectures is kind of engage with the audience. In this case, it's a Zoom. So I typically like to show cases and basically have you think about the case. And basically, I'll show you what, you know, and we'll go over differential diagnoses and what we see on pathology. Then we'll come up with the final diagnosis. So the first one is a 52-year-old male patient with a sore on his tongue. Oops, sorry. Past history, sorry, let's see. Lesion's been on the lateral border of the tongue and has been present for approximately 3 weeks, okay? The key with any oral lesion is 2 weeks. So just remember that. Anything that's been there for more than 2 weeks, we kind of get concerned because it should resolve within typically 7 to 14 days. So if it's lasted more than that, you got to think about, you know, other causes. In this patient's case, it caused some discomfort when he eats acidic foods, doesn't recall biting his tongue, has no history of herpetic lesions, which I'll go over, and has had a few canker sores in his mouth. Medical history, nothing significant, just hypertension, diabetes, and seasonal allergies. Patient has smoked 2 packs of cigarettes per day for the past 20 years. So that's very important. Oral cancer makes up about 3% of cancers in the US. Anytime a patient smokes, they're about 20 times more likely than a non-smoker to develop oral cancer. So always remember that. So if they have a history of smoking, be a little bit more cautious. And if they smoke and they drink, it's about 32 times more likely that they'll develop oral cancer. So this is what you see on clinical examination. We're looking at the lateral border of the tongue. See the small ulceration with this white border. So as I said, if I was doing this at Phoenicia or at another location, I would ask you to describe it. So you see a 2 to 3 millimeter ulceration with the lateral border of the tongue. Margins are slightly elevated and white, meaning keratotic. Differential, patient is a smoker, so you always have to think of cancer, but it's low on the list, but it's still there. Squamous cell carcinoma, ulcer, and chronic infectious ulcer. How would you manage them? So you have to think about how you would address this. So the biggest thing is you always check the teeth. Rub your fingers along the teeth, make sure there's no sharp edges or broken teeth it might be rubbing against, or maybe a bone that's protruding on the medial aspect of the lower jaw, or any broken restoration. So you send it off to pathology, comes back as granulation tissue with inflammatory cells at the base of the ulcer. They did special stains, but they didn't disclose, nothing came up, such as fungi or mycobacteria. Diagnosis, it's again chronic inflammation. There's no pearls. So it's a basically chronic non-specific ulcer. Basically, you probably bit into it or rubbed against the tooth. So what are your clinical features of acute and chronic ulcers? This is important to know. Acute ulcers, typically they're painful because they recently bit into it or traumatized it. They have a yellow base with a red halo. You ask them, they'll typically tell, oh yeah, I was eating, chips, or I ate something, it slipped and I bit myself. And typically they'll heal within 7 to 10 up to 14 days. Chronic ones, little or no pain, yellow base, elevated margins, could be a history of trauma, delayed healing if irritated. Clinical appearance mimics cancer and an infectious ulcer. So what do you think about when you see a chronic infectious ulcer? Syphilis, as you know, it's on the rise, TB, histoplasmosis, and other deep fungal infections that I mentioned. The clinical features can mimic cancer because it lasts more than 2 weeks and it doesn't heal. Is biopsy necessary? Yes, and you also send them off for culture, of course. And, at this point, based on what it comes back as, can treat them. And if there's any questions, I'll refer them to ID. Case number 2, 24-year-old woman seeks treatment for a sore mouth. So it's a female. They're more prone to these ulcers, just as an FYI. She's had pain for about 5 days and now finds it difficult to swallow and talk. Okay, so you're thinking it's probably something in the posterior pharynx towards the soft palate. She doesn't believe that she had any intraoral blistering. She's had no eye, skin, or genital lesions. Why is that important? Because you think about, the pemphigus, pemphigoid lesions as well, of course. And has not had a fever or any other systemic symptoms. Past medical, pretty much it's negative, just taking oral contraceptives and no allergies. So when you examine her, you see these lesions. So how would you describe this? You see one on the right side, close to the commissure, and one on the upper lip on the inside. So it's a small ulceration, measuring, a few millimeters, with a yellow base and that halo. Under the tongue, when you have them roll their tongue up, you see similar lesions. Also on the buccal mucosa, there's another one further back by the retromolar area. You see one, another one by the vestibule. And this is the soft palate. And towards the hard palate, you see this. So what do you think of? It's a female. So you think of canker sores a lot of times, and there's different types, which I'll go over. You can also think of erythema multiforme, which I'll go over, which we all know. You can think of pemphigus as well. But if you remember, pemphigoid is typically the one you ask about ocular lesions. So you look at the conjunctiva. Why not include primary herpes? There's no systemic. They hadn't had that prodromal, and they haven't had any gingival lesions, and typically occurs along the keratinized tissue, such as the gingiva or at the right at the junction of the lower lip, the vermilion cutaneous junction. Why is erythema multiforme unlikely? Those lesions are typically much larger, and the patient has no history of herpes or any drug triggers. And there's a big list, as we all know, the medications that may cause erythema multiforme. Why is pemphigus less likely? They're usually larger, and there's no history of blistering. And if you remember, there's something called the Nikolsky sign. If you push on it, it sloughs off. So basically, this patient had Aptus Stomatitis, basically this small canker sores throughout her mouth. So if they don't respond, usually give them a little bit of time. You can give them topical steroids, but if you suspect anything, you can also biopsy them. But again, given the number of lesions, you kind of know it's herpetiform Aptus Stomatitis. So this patient was treated with a mouth rinse, tetracycline. Some people will use steroids. And at this point, I'd like to get oral medicine on board just in case I don't miss anything. But these lesions will typically resolve within a few weeks. Aptus ulcers. So these are the breakdowns of the common ones we see. Minor, typically less than half a centimeter. Major is larger than half a centimeter. They get fairly big, actually. And the herpetiform, they're typically small in size like the minor apthi, but you see just clusters everywhere, just like that female patient I just presented. So you see 10 to 100 of these lesions throughout their mouth, and they're usually miserable. And those are the typically topical steroids, just controlling their pain, and usually they will resolve. So basically, these are pictures of the ones that I just mentioned. The minor one on the lower right, herpetiform is the bottom right one. The upper one is just the regular minor apthi, and the major one is the lower left one. You see how big those ulcerations become. So things you have to remember between a canker sore and a herpetic lesion, cold sore. Herpes, you think of the herpes simplex virus. Triggers, it's a variety of things: stress, trauma, something happened, they're depressed. There is a prodromal symptom. Sometimes they'll feel this tingling sensation coming on. As far as there's viral cytopath changes, vesicles typically precede, so you'll see those vesicles on their lip and at the junction of the keratinized tissue. As I said, it takes place on the keratinized mucosa. You see multiple ones, and you can give them antivirals. It will cut it by a couple of days, but again, by the time you see them, it's already too late. But you see the difference with canker sores, Aptus ulcers, you give them steroids. Some give tetracycline. Herpes, if you catch it early, especially in the prodromal, if they start getting those symptoms, you can give them the antivirals. Another picture. If you notice on your left, those are Aptus ulcers, whereas on the right, those are herpes lesions on the palate, and the palate is keratinized tissue, so that's how you differentiate it. Whereas the previous picture that I showed you of the 24-year-old, that was mostly on the soft palate, so there's less keratinized tissue back there. Behçet's, I'll just mention it. I've never seen one. It's an immunodysfunction, vasculitis. You see it on the non-keratinized oral mucosa. You can see it on genitals, eyes, joints, and they have CNS changes such as headache, nerve palsies, and inflammation. So if you suspect this, you can ask them these questions. But again, I have never seen one. Treatment with Behçet's is corticosteroids and other immunosuppressive medications. At this point, I'll get the primary care on board, especially if we're going to be using oral systemic medication. Erythema multiforme, I saw one in residency. There's minor and major. The minor one's usually triggered by herpes simplex. The major one, the one, typical board question that we see is Stevens-Johnson syndrome, is typically triggered by medications. And ones we prescribe in the oral cavity can cause it as well, such as the amoxicillin, the penicillin families. And they have hypersensitivity to infectious agents, drugs, or sometimes it's idiopathic. Clinical features, they have big ulcers. They're on the larger side. They have also target skin lesions, which are typical when you see these. And they're typically sick when you see these patients, and they're self-limiting, but they may recur. And treatment is supportive care, and sometimes they give corticosteroids. Here are some pictures, as you can see, on the buccal mucosa on your lower left. The upper right shows it on the tongue, and the lower right shows it on the buccal mucosa and also towards the retromolar area. Ulcers. So here's another case, things that may walk into your office. You see an asymptomatic 64-year-old male for an annual examination. You see this opacification, whiteness on the buccal mucosa, but he has no symptoms. He has a 40-pack year history of tobacco use. So if you remember, I mentioned if they smoke and not drink, they're 20 times more likely to develop oral cancer. But if they smoke and drink, they're about 32 times more likely. And the reason is alcohol typically will desiccate the tissue, so the toxins will stick to the tissue better. And the most common areas where oral cancer may occur is the lateral border of the tongue and the floor of the mouth, intraorally. Extraorally, it's the lower lip, and typically due to the sun rays. As far as medications, patient has xerostomia related to his Parkinson's disease. So this is what you see when you retract the buccal mucosa. You see this white patchy area, it looks leathery. This opacification, it's basically leukoedema. So they get this. Sometimes the smokers, the heat will do it. You also see this if you have any Indian or Pakistani patients, you'll see this because what they do is they chew on something called a betel nut. It causes euphoria, and they typically will keep it in their cheek, and this is how they typically will present. So be suspicious if they're Indian or Pakistani and you see this, you got to think about the betel nut that they're chewing on. A lot of them have it, they don't have it here, but they have family members who bring them over. Also on this patient, you see this lesion. You look at the floor of the mouth, we're looking at the mandible. Those are the sublingual caruncles where the sublingual and submandibular glands drain. You see this ulceration, alteration of that caruncle. So you see a 3 millimeter ulceration with keratotic changes. Remember, he smokes along the right sublingual caruncle. So what do you think of? Again, he's a smoker. Obviously, you think of squamous cell carcinoma. Or it can be a traumatic ulcer if they keep a toothpick or a pencil in their mouth. They constantly traumatize it, or it can be a chronic infection. But most likely, given his history, you think of a neoplasm. So what should be done next? It's been there for a while. Patient smokes, so it merits a biopsy. You can bring them back in 2 weeks, but again, if you have high suspicion, you can send them out if they tell you a correct history. You get the biopsy. It shows basically normal epithelium on top. Then the epithelial islands in the submucosa, as you notice, as it works its way down. High magnification shows invasive squamous component with mitotic changes. So diagnosis, squamous cell carcinoma, which makes up, as I said, about 3% of cancers in the US. It might have dropped recently because smoking has dropped, but it's around that range. So the patient was pretty much treated with primary surgical resection of the floor of the mouth along with a modified neck dissection. Some people say you can do radiation therapy, but it's usually surgical. But the radiation, typically they'll get if they have lymph nodes are positive or based on the size of the lesion. And as we all know with radiation patients, given where they radiate by the salivary glands, they're more prone to xerostomia and osteoradionecrosis. So if there are any primary care physicians listening, if you have any patients who have oral cancer, it's always recommended to refer them out to have any oral treatment done, meaning extraction of teeth, before any of this radiation is started. Side effects of radiation, initially, look at mucosal ulcerations. Because of the xerostomia, they get pain, dysgeusia, candiditis, dermatitis, especially on the outside where it's radiated, erythema, and they have alopecia. So when you look at these patients, you can actually tell there's certain areas they don't need to shave because they've actually lost the hair follicles. Permanent effects of radiation, xerostomia, because of based on the location of the tumor and where they're radiating, if it goes through some of the major glands, such as the sublingual gland, submandibular, and the parotid gland. Cervical caries, meaning they have a lot of cavities just at the border where the teeth meet the gums, and it's because of the lack of saliva flow, and basically they accumulate there. Osteoradionecrosis with these patients. So we always have to get a history on these patients, find out how many RADs they received before we proceed if we have to do any type of oral surgery. Epithelial atrophy, alopecia, as I mentioned, and some will get hyperpigmentation in that area. So I emphasize this because I've seen a lot of cancers missed. So anytime these are seen, you want to, address these early and refer them out, because the minute they can reach the lymph nodes, the prognosis drops. So anywhere from 25 to 50%. So sooner, just like any other cancer, the sooner, the better the outcome for these patients. It just tells you what this patient's survival was. It had spread to his lymph nodes. Unfortunately, this patient passed about a year after this photograph was taken. As I said, the common areas to inspect: the lateral border of the tongue, the floor of the mouth. It's because where it accumulates and where the toxins sit. So just always do a good examination, looking at the sides of the lateral borders and at the floor of the mouth. One common mistake, one common referral that we get is patients look, and all the way in the back, they see the lingual tonsils and they think it's a lesion. That's actually normal anatomy. So, so just keep that in mind. The lingual tonsils are all the way in the posterior 1/3 of the tongue, and some people mix them up, they panic, and they refer them out for biopsy. And we have to reassure the patient and the doctor or the dentist that this is normal anatomy. Other examples, as you can tell, they're just fungating masses. They don't resolve in 2 weeks, and typically these patients have had a history of smoking. As I said, discovering them early, less than 2 centimeters, usually is stage 1, but obviously we have to measure the depth of invasion, which is a big factor as far as them getting a neck dissection, which the head and neck surgeons do. Overall survival is about 50%, has remained about the same. Up to the early 2000s, it's not on this, it's about the similar range, about 50%. Another case, 59-year-old male is hospitalized for chronic alcoholism. He's also had a long history of cigarette smoking. He's had a lip lesion that has persisted, that has caused him only mild discomfort. The lesion has increased in size over the past 2 months. So he presents to you, and this is what you see. So how would you describe it? Chronic ulcer covered by white exudate, margins are slightly elevated. Differential, obviously he smokes, so you got to think about squamous cell, but you also have to think about infectious process or a non-specific ulcer. Then you look at the floor of the mouth and you see these kissing ulcers in the floor of the mouth and the ventral tongue. It's not connected, but it's very close to the lip. So you think of some infectious process because there's actually a separation. So most likely it's worked its way sub-Q and worked its way into the floor of the mouth. So what do you think of? Syphilis, TB, deep fungal infection. He's an alcoholic, so he's probably immune suppressed. So you take a biopsy, send it off to microbiology and path. And so it shows expansion of submucosa with macrophages, and high magnification shows the cytoplasm containing a lot of abundant microorganisms. If you look at the arrow right in the middle, that's what we're pointing at. So are these viruses, bacteria, or fungi? You're not expected to know this, but I reviewed this and the pathologists already know this. It's fungi. They're basically too large to be viruses or bacteria. So it basically came back as histoplasmosis. Okay, so it wasn't cancer, it was just an infectious process. He also had this, the postauricular area. As you pull the ear forward, you can see this. So he was treated with ketoconazole, antifungal, with a resolution of his histoplasmosis. If you look at the before and after, you notice how clean it is. So always, you got to remember these infectious processes because, you know, they can come up, especially if they're immune suppressed, some of these homeless people, or if they're on a lot of immunosuppressants. Think about the pathogenesis, inhalation of the spores, symptoms, cough, fever, weight loss is very important to ask. So it's also very important for oral cancer. The primary site, lung, they might have it there. Oral lesions, again, they're non-healing ulcers, and if they've been there for more than 2 weeks, you get concerned. Microscopically, you see the granulomatous inflammation, and the treatment are the antifungals listed below: ketoconazole, fluconazole, itraconazole, and amphotericin B. But again, at this point, we consult the ID doctors. Some basic features, just so you know, that the fungi: histo, coccidio, blasto, and crypto. So anytime that you see a patient and you're suspicious of squamous cell carcinoma, always feel the neck. So if you're not sure, you know, you should refer them out. If you suspect any lymphadenopathy, especially on the ipsilateral side, you got to get concerned. And if the lesion is within 1 centimeter of the midline, it can spread to either side. So if you do a good neck examination, sometimes you can pick up lymph nodes, but typically it has to be at least 1 centimeter or larger for you to palpate it. This just shows the microscopic finding on this patient. So I'm going to go over some questions. Then I've also submitted 3 questions, which we'll ask that you answer at the end of this lecture. So histologically, the base of a traumatic ulcer, which is one of the first cases that I presented, is composed of what type of A, granulomatous, B, simple squamous epithelium, C, cantolytic squamous cells, D, granulation tissue covered by fibrin exudate, or reduplicated basement membrane. So it's a traumatic ulcer. They bit into something, or they're broken tooth, or they traumatize it with a toothpick. Some people keep toothpicks or pencils in their mouth. So the answer is D. It's granulation tissue. So the most important risk factor for oral cancer is tobacco. As I said, 90% of neoplasms in the oral cavity are squamous cell carcinoma, and tobacco is the most important risk factor for oral squamous cell carcinoma. Not as much in smokeless, which the baseball players used to do, but there have been some reported cases. Some of you may remember there was a baseball player by the name of Tony Gwynn who played for the San Diego Padres. He did smokeless tobacco, and he did develop oral cancer, but not as common. So you see this patient, Mr. Hakop walks in. You see this ulceration on the floor of the mouth and lateral border of the tongue. What do you think of? You look at the area, there's some teeth, they might be broken down, but he does smoke. So it's just a chronic ulcer with rolled margins. So basically, given his history that he smokes, you got to think about malignancy. The questions you always ask is, you know, how long they've been smoking, as I mentioned, and how long the lesion has been there. So what does a 40-pack year history of tobacco use mean? Basically, this is just a way, for somebody who don't know, a way of quantifying the amount of tobacco used by a patient. And 20 pack years is considered a significant milestone. So typically anything above that, got to be more concerned. I've had patients who stopped smoking more than 5, 10. I had one who was more than 14 years, and he still developed oral cancer, unfortunately. 14 years after stopping tobacco use. But this is just the definition, what a 40 pack year means: 1 pack per day of cigarettes for 40 years. So you can do the math. Anyway, you know, if they smoke half a pack, you just do the multiplication. You can figure that out. I'm going to show a few more pictures that I showed just to kind of refresh your memory. And diagnosis for recurrent painful ulcer. If you remember, I showed you that 24-year-old female. you think of minor epithelial ulcer, but you also have to look at where the lesion is. If it's on the keratinized, you got to think about more herpetic, but if this is on the non-keratinized, if you notice that pinkish, whitish, the pink, that's a little lighter, that's the keratinized tissue, whereas the ulcers in the non-keratinized area of the vestibule. So which of these following oral diseases has a relatively short self-limited course? I went over these: secondary herpes, erythema multiforme, herpes zoster, Aptus ulcer, or all of the above. Pretty much all of the above. As I told you, a lot of these will resolve within 7 to 10, sometimes 14 days. Erythema multiforme might take a little longer, but it gives you an idea that these will all resolve. So which of these would be considered an iatrogenic injury? Traumatic granuloma, tissue ulcer, cotton roll ulcer. Cotton rolls are those rolls of cottons that they put in the lip, dental professionals use to retract their lips when they're doing the filling. Frictional hyperkeratosis, or all of the above. Cotton roll. There are times where, some people will forget and leave those in there, and actually when you take it off, the entire tissue will slough off with it. So you got to get a good history from them. Granulomatous inflammation is characteristically seen in which of the following? So TB, histo, blasto, or coccidia, or all of the above. You see it in all four, actually. Oral TB is A, B, C, D, or E is granulomatous, may appear clinically like primary syphilis, is usually secondary lung infection, is contagious, or is it all of the above? It's all of the above. Basically, those are all the common signs and symptoms of oral TB. So another thing, if you don't see a lot of these, but if you see an ulcer, if they don't have teeth, you got to think about an appliance they might be wearing that might be causing that. So sometimes the flanges of the dentures might be digging into the gums or the floor of the mouth or the vestibule and could be causing. So typically if they adjust the denture, a lot of these lesions will resolve. So usually we'll just buzz it off or send it back to the general dentist and have them come back in 2 to 3 weeks after the adjustment's been made, and typically these lesions will resolve. That's basically what you see, this fibrin exudate with granulation tissue. That's the granulation tissue that I'm pointing at on the microscopic, on the slide. We're almost done here. 35-year-old male received therapeutic radiation for carcinoma of the base of his tongue. Radiation fields ports were bilateral, and the radiation passed through the major and minor salivary glands. So this patient is most likely to develop necrotizing silometaplasia, scarring of salivary glands, sinus retention cysts, benign lymphoepithelial lesions, or mucus extravasation phenomena. So scarring of the salivary glands. So that's how you get the xerostomia. Typically, these patients will get about, up to 60. But typically, as that number rises, they're more prone to getting xerostomia. So I usually will, talk to the radiation oncologist to get an idea where they receive the radiation if they're coming to see me afterwards. So it's very important to get an idea. And these patients, you can tell them to take, to sip on water throughout the day. There are medications, as we all know, we can use. And there's our artificial saliva too, that we usually will tell them to use to kind of keep their mouth lubricated throughout the day. Immunomodulating drugs have a rational basis for the use in the treatment of which of the following oral diseases? Pemphigus, pemphigoid, aphthous, lichen planus, or all of the above. It's actually all of the above, because some of these you do treat with topical steroids, but if it becomes systemic, you can also give them oral steroids as well. So you see this lesion, recurrent, painful, acute ulceration. It measures over, looks like with a centimeter and a half. That's on the non-keratinized mucosa. So remember, keratinized is herpetic, non-keratinized is typically an aphthous. So it basically is, diagnosis is major aphthy. Again, we'll watch these patients for a couple of weeks, and as I said, they will resolve. Thank you. I can take questions now or at the end when Dr. Bretan is done.
Thank you, Dr. Kotikian, for that very informative lecture. We will hold the questions to the end. If we can, Dr. Kotikian, if we can have you stop sharing your screen.
Of course.
Thank you very much. Again, well, please, we ask everyone to stick around, and we will take the Q&As at the end of the session. Dr. Bretan is, as we introduced last week, he's a urologist and kidney transplant surgeon. He is the California Medical Association's 52nd president and will serve on the CMA's executive committee in this role for 1 year. He is the first Filipino-American physician to serve as CMA's president. He practices in Marin and Sonoma and Santa Cruz counties. He has served in multiple leadership positions. He also is the current president of the California Urologic Association. And as we discussed, as we mentioned last week during his introduction, Dr. Bretan is the founder of a nonprofit and serves as the director of a nonprofit organization, Life Plant International, which is a charitable organization that furnishes life-saving transplants in developing countries. And for the work that he's done on this front, he has been recognized by the American Medical Association with the Benjamin Rush Award for Citizenship and Community Service. We are really, really fortunate that Dr. Bretan is able to join us today to talk to us about some of the work that CMA is doing. Dr. Bretan has prepared a presentation for us, which I will launch, and then we will subsequently hear Dr. Bretan's remarks once we finish with our with the remarks.
To all of your membership, how busy our CMA staff and our executive committee have been, and the incredible job they all have done since this COVID pandemic. Now, much has changed in this. Thank you for the invitation to speak to you tonight. Today, we're faced with a triple pandemic and its secondary financial downturn, and now violence from racial disparities that have been pent up. CMA has been engaged in COVID-19 responses from shortly after the first cases in our community, after transmission, and we continue to fight for physicians and patients in the healthcare system while it undergoes seismic shifts. Now, I'm a urologic transplant and laparoscopic surgeon, and I want to thank the doctors, President Galstian and Vice President Sapelian of your Armenian American Medical Association for the opportunity to report to all of your membership how busy our CMA staff and our executive committee have been, and the incredible job they all have done since this COVID pandemic. Now, much has changed in this world since then, and we are now closing in on more than 120,000 deaths in the United States from COVID. Our ability to provide care has dramatically changed from one of the most difficult scenarios we could have ever imagined. But it is constantly evolving, and what I know so far, I remain optimistic for all of us. Let me digress and review the most incredible past several months that the California Medical Association has ever had. In mid-January, significant COVID issues started to rapidly escalate. To meet this challenge, CMA became available continuously, ready to release important communications, sometimes twice a day. Our executive committee now meets at least twice per week, oftentimes 4, via Zoom, And our CMA staff has retooled itself to be exclusive to respond to almost hourly changes concerning government input, developing to this technology to more safely screen them. But I've been using telehealth for more than 10 years. So in order to aid those not so technologically inclined, we push for immediate telephonic coverage in order to help screen to convert more of our patients into telehealth. In 2010, I was the only telemed urologist in the country. And at that time, I controlled my telemedicine robot avatar by a joystick connected to my laptop. And that enabled me to cover 24/7, 7 Northern California rural counties. And that enabled me to cover almost 10 hospitals. Most never had a urologist at their hospital. And that enabled me to come by on a regular basis to perform complex cancer surgeries at small rural hospitals so that patients could be close to their families and, most importantly, their primary care physician. I was also enabled to cover my practice worldwide on the other side of the world when I left for medical missions. Now, beyond my wildest dreams, telemedicine has emerged as a standard of care. It's just not here for this crisis, but for all crises, whether it be a pandemic, a hospital, or home evacuation from fires, earthquakes, or floods. It enables doctors to see their patients wherever they emergently move to, and thus provides the best continuity of care should they need medicines, testings, or advice on hospitalization. It not only preserves, but it enhances the doctor-patient relationship, not replacing, which is especially important during these times of crisis. I'll feel better when all my stable patients are ultimately seen in preparation should they need this technology. And in fact, today, delay of diagnosis or treatment is now becoming a leading cause of morbidity and mortality compared to COVID. We should all strive to use this technology to safely evaluate our patients. But most importantly, we can alleviate fears of our patient by not coming to your offices with non-politicized education concerning COVID. Now, telehealth is the future. And the CMA has asked the governor to make permanent the removal of the obstacles to this technology and continued reimbursement for these services, no different than in person. I want to thank the CMA staff for rapidly making guidelines and developing webinars to help our physicians deliver care almost immediately with this technology. Now, CMA is now the largest state medical organization in the country. And how did we get there? We got there with a foundation built from a micro defense to a tobacco tax to support Medi-Cal. That enabled us with raising $2.2 billion for $40 million in new GME funding. It enabled us to award 72 GME programs, new, existing, and expanded programs throughout the state of California. And most importantly, it ensured a pipeline for future doctors by giving over $340 million in loan forgiveness payments. I'd like to highlight the work the CMA's subsidiaries, Physicians for a Healthy California, is doing the front part of access to care by managing those $2.2 billion gotten from the tobacco tax. Our Well-Physician California was born of a need to deal with burnout from individual to institutional causes and to integrate this with physician practices. Our statewide physician service organization, known as Innovite Solutions, was born and fueled by the need of these things as prior authorization burdens, burnout, and surprise billing. Now, with these subsidiaries, the last subsidiary was a statewide partnership with Blue Shield and their two subsidiaries, Altace and Aledade. But with all of these subsidiaries, Physicians for Healthy California, Well-Physician California, and Innovite Solutions, we built a strong foundation in order to prepare us to deal with this virus. And CMA mobilized shortly after the California's first community transmission. We were early in asking the governor to move from a containment strategy to a mitigation strategy. We sought the establishment of a state emergency, which would give local governments and local health officers more flexibility in responding to COVID-19. It also would give federal qualified health centers, as well as rural health clinics, the ability to get telehealth care paid at a rate equal to in-person patient care. It was obvious that telehealth could provide care in a way that decreased the potential for viral exposure. So we sought early implementation of a law that we passed last November 2019 that CMA successfully sponsored, but it was not to be implemented till the early 2021. But when the federal government waived the application to privacy laws for telehealth, we sought to our governor to have conforming waivers for California privacy laws so that differences would not create barriers to telehealth implementation. We also understood that licensing and credentialing requirements could create barriers to ensuring adequate workforce to respond to COVID emergencies, and we sought waivers to address those issues as well. Now, payer administration burdens would only serve to complicate the landscape for physicians who were trying to identify ways to contribute to the effort, either through providing COVID-19 care or revamping practices to protect public health. We requested relief from those. We sought workforce flexibility so that it would enable us to scale up quickly while protecting quality and limiting administrative burdens. This included waiving physician supervision ratios, allowing pharmacists to perform COVID-19 testing and allowing podiatric care for inpatient care. We also understood that physicians would be doing what they could to decrease public health impact of COVID-19 by limiting in-person care and eliminating elective care when required. And that commitment would strain their practices, and at the same time, insurers would still be collecting hefty premiums. So CMA requested that insurers provide supplemental financial assistance grants to their network physicians. And we're pleased that most of our requests relative to telehealth and workforce flexibility have been implemented. There's still much work to do on helping our physicians maintain practice viability, to help ensure that they're there to provide care should they need it because of COVID-19. CMA's relationship with the Governor Newsom is longstanding, who sought shortly after his inauguration to be the healthcare governor in an exclusive meeting with the executive committee of CMA. And now of all times, we're going to hold him to that. Believe me, lack of adequate testing has been thoroughly transmitted to the governor, and he has implemented a COVID-19 testing task force, which CMA is part of. That combined with our strong relationship, we are now seeing the benefits and immediate result capability. And use of contact tracing with expanded testing will help us return workers back to the public safely. My office was exposed, 2 of our members were positive, but all the rest of the members were screened in less than 3 hours. A significant lack of PPEs for the small and solo group is noted. I'm part of that group, and their voices are often muffled by that of public health, clinics, and hospitals. Yet in terms of prevention of spread and treatment of COVID patients, they are one of the most effective front lines if we're to contain this disease. The governor has purchased at least $5 million of PPEs and masks for all, and we have asked that a portion of that be earmarked for our small and solo group. A recent letter, we asked the Health Officer Association of California regarding the lack of distribution so we could study that. And a survey was sent to deal with the maldistribution. And just last week, the state has agreed to have CMA lead the distribution to the small and solo groups throughout the state via our local component medical societies. Now, due to immediate reductions in public crowds, it seems that California will not see the large peaks seen in New York, Louisiana, Michigan, and Washington. However, in March, the ramp up to a possible surge from COVID patient hospitalizations at that time estimated the shortages in ventilators, and our physicians and their local medical staff governments were given guidelines by CMA in order to conduct triage should this be needed. And it may still be needed. And I want to thank Alicia Wagner, our legal counsel, along with Francisco Silva, for rapidly getting these flexible guidelines, which enable our local medical staffs to customize their needs to specific changes in their hospital. One of the most common questions from our membership was that of liability in such situations. Early on, CMA successfully received state waivers in surge situations to ease liability ratios used for supervision of allied health professions to ensure workforce could expand capacity quickly while protecting quality and limiting administrative burdens, as in license renewals. In other situations, surgeons like me have been asked to delay surgeries or possible care of COVID patients outside of their specialty norms, and that may result in liabilities. Immunity from such liabilities for all physicians is sought with our governor by continuous discussion with our executive committee. But as the surge response becomes less likely, CMA was standing next to the governor when he announced the creation of the California Health Corps, that program that allows healthcare providers to be called into service during emergencies while receiving payment, and more importantly, malpractice coverage. We had over 800 volunteers signed up in the first 10 days. CMA recruited some of those volunteers as a California delegation of physicians that traveled to New York to provide patient care and bring back lessons learned. While all CMA and our executive committee's hands are tied to COVID response at this time of the crisis, many of our executive committee members met with legislators in Washington, D.C. in early February at the American Medical Association's National Advocacy Conference. We concentrated on surprise billing at that time, which is tabled for now. We met with House Speaker Pelosi, Minority Leader McCarthy, numerous other congressional members such as Nunez, Ruiz, Panetta, Sanchez in our state, as well as our U.S. senators. With the last and fourth stimulus bill, we averted the worst form of surprise billing fixes. And in addition, we received $300 billion to provide for uninsured COVID patient care, and $100 billion was distributed more than a month ago. To help policymakers understand the stakes, we conducted surveys in public health and found out that public health officials were being attacked for announcing healthcare policies. Additionally, we supported them with a letter that has gone out, and you can find that online. And we also supported the governor's statewide face mask covering. But additionally, over 8 days, a month ago, CMA surveyed physician practices about COVID-19 impact. Almost 3,300 physician practices responded to the survey, and that was a record response. The results are stunning, and you can find them online, but it helped the California Medical Association show the need to support our physician practices to our legislators. 95% of physician practice are significantly worried about fiscal concerns. 64% will see a significant drop in income to less than half. Here's one of our physicians. As it looks now, it's likely I will have to close the practice. Volume is down significantly despite moving to telemedicine. Due to financial concerns, and current patients are canceling visits or asking to push back appointments. No new patients are calling. Viability of the practice is less than 30 days without financial support. 49% will lay off or furlough their staff, which gives us 13 million patients at risk of losing all coverage, which is a third of California's patients. All counties in California are seeing this downturn, including Marin, one of the most affluent counties in the country. Another one of our physician members said, although the volume is way down, I'm so much more exhausted, under more stress than before. This comes from financial downturn of the practice, trying to do what's right for my employees and often living paycheck to paycheck and trying to maintain a sense of calm to my very overwhelmed OB patients. As physician practices have struggled to stay open, publicly traded health insurers have continued to post robust profits during COVID-19 outbreak, and millions of Californians continue to pay full price for their health insurance premiums. Health plans have seen their expenses drop as Californians stay home, and many forgo scheduled preventative and other healthcare services. CMA and the Pacific Business Group on Health have joined in coalition to pursue a proposal to get insurers to use some of that windfall they've gotten to keep physician practices open. This group is a not-for-profit public benefit organization based in California, consisting of large public and private purchasers of healthcare. In addition to our advocacy, CMA has provided resources to help provide guidelines on reopening healthcare practices. Last month, we issued guidelines. We're proud to have the state reference those guidelines in their document. We created a toolkit for practices and are hosting a series of webinars on reopening. For those that have already occurred, those that are changing, a general overview of the best practices for reopening, and one focused on pediatrics as well as numerous others. And these are all available to download on our website. We continue to help support physician practices. Now, CMA's wellness subsidiary developed Care for Caregivers after recognizing additional strain providing care to COVID-19 patients. We present or enable peer coaching available to all California physicians, nurses, physician assistants, nurse practitioners, respiratory therapists, all providing emergency or intensive care to acutely ill COVID patients at no cost for up to 30 days. CMA will also be hosting regular series of virtual grand rounds for the state's clinicians, evolving the understanding and management of COVID-19 patients. Please provide your feedback if you have any of your interests and complete the survey forms. CMA website is now one-stop shop for the latest and most current confirmed information, using regularly updated toolkits on financial assistance, telehealth, employer considerations, and reopening practices. Our first webinar had greater than 800 attendees to deal with delay of care, employment practices, staffing issues, med staff issues, advocacies. You can find all our letters to state and federal legislators and leaders online, as well as CMA's recent responses to COVID. Please encourage all your colleagues to take advantage of this great COVID-19 resource. Now, California began 2020 with a lot of hope and a strong bill of financial health, a strong economy, historic reserves, and a structurally balanced budget. Unemployment rate of 3.9% was the lowest since the Great Recession peak. The proposed 2020-2021 governor's budget reflected a $5.6 billion surplus, but our recession resulting from COVID-19 pandemic has dramatically changed the fiscal outlook of the state in a very short period of time. The result is an overall deficit of $54 billion to be made up of increased costs due to caseload increases in safety net programs and a dramatic decrease in revenue estimates. The governor's May budget revision resolves the projected deficit through a series and mixtures of solutions. Most notable are the trigger restoration. The May revision proposes several reductions, including dramatic cuts to Medi-Cal, and a redirection of the tobacco Proposition 56 tax that can be restored if the federal government provides the state with an additional $14 billion in federal funding. That puts at risk many of the Medi-Cal program funding, and much needed on top of what is needed for COVID-19 coverage. The healthcare cut proposed to eliminate all optional benefits to Medi-Cal patients, including podiatric, optometric, and most dental benefits. And it's an attempt to utilize $1.2 billion of Proposition 56 tobacco tax and revenues in ways that do not align with the intent of the Proposition 56 approved by the voters in 2016. This redirection of Proposition 56 revenues would reduce supplemental payments and provide to certain CPT codes that many of our physician Medi-Cal providers need. CMA has worked hard to increase Medi-Cal patient access of care through a creation of a loan repayment that I had reviewed from funds from Proposition 56. The program Cal Health Cares has provided loan repayment up to $300,000 for exchange of 5 years of service in an underserved area with a patient caseload of more than 30% Medi-Cal patients. The program's wildly successful, and we need it now more than ever. And it helped us place hundreds of physicians and dentists in underserved communities throughout our state where they're needed the most. The program was prepared to announce another year of cohorts providers in early last month. However, the state withheld the announcement to sweep the remainder of the funding as they needed to make up the deficits. Typically, the development and enactment of a state budget is a 6-month process. This year, it is extremely truncated. It's also different and unusual because many of the legislators are sheltering at home. This increases the importance of local physician voice, your voice. For physician and patients to stave off dramatic reductions in our Medi-Cal program, CMA enlisted all physicians to engage in this fight. Responding to CMA's budget call to action and becoming a social media ambassador were ways to amplify the opposition during these times of sheltering at home to these devastating cuts. The Coalition to Protect Access to Care social media campaign was successful. CMA is a member of that coalition. The coalition has helped us increase our reach and engagement. And in fact, CMA's advocacy persisted continuously and together. And as a result of our CMA physicians have just not stepped up, but their thousands of calls to our legislators are successful. I'm proud to announce that the late May Senate Budget Committee passed their version of the state budget, a dramatic improvement from that of the May revision of the governor. The Senate budget rejects redirection of all Proposition 56 funds, and it maintains both the supplemental payment program and loan repayment program administered through the California Medical Association Physicians for Healthy California. Instead of redirecting Prop 56, the Senate even adopted a lower caseload cost estimate, and it proposed to increase through a managed care organization tax to raise an additional $1 billion, so greatly needed during this crisis. The Senate's proposal additionally does not include physician license fees increases and rejects cuts to our traditional Song-Brown GME supplemental program. Now, as CMA lobbied assembly leaders, both houses became aligned by last week. And today, we are successful. We have a bill that includes no cuts to our Medi-Cal patients on to the governor's desk for signature. I want to shout out to Janice Norman. He's the head of our state lobbyist team. CMA supports him greatly. CMA also supports the HEROES Act that we recently placed online, a letter from me to Speaker Pelosi. CMA top priorities, including increases to our physicians and Medicaid matching funds, helps protect the supply of international medical graduates. It provides medical student relief. It includes many of our CMA-sponsored bills to allow California physicians access to federal public service loan forgiveness. It was passed by the House of Representatives. My supportive letter, as I said, is online to Speaker Pelosi. Parts of the bill now are being negotiated with the Senate, and we expect another bill from Congress by the end of July. CMA is fighting hard to ensure that a compromise bill continues and that it includes significant support for our physicians and their patients. I'm a shout out to Elizabeth McNeil, our federal lobbyist, for all that she has done, because it has helped millions of our patients and thousands of our doctors. Now, in closing, I want to say I am humbled and honored for the privilege of addressing you tonight. As for me personally, it is a fulfillment of a life's goal. As a son of a disabled veteran of World War II, who is also an immigrant and a strawberry farmer. I grew up as a child farm laborer, and I know what it is to be without adequate health care. My greatest motivation is to give back to society for my good fortune. Most of my patients speak no English, more than 90%. Many have inadequate or no medical insurance. My presidency has been dedicated to giving these patients and the millions of hardworking Californians like them a voice. We have an incredible opportunity to boldly change the way healthcare is delivered as it is changing today. We know that it's best to serve the patients by having healthcare be determined by physicians, must be physician-led. I share with my patients that I know fear, as I was a scared 8-year-old boy at one time watching my father almost die, only to be saved by a caring surgeon. And that is why I'm a surgeon today. I use that personal story today as a surgeon to help save lives by allaying fears of delayed treatment that I see in my patients and many other patients. Certainly, life in medicine has changed forever in the world, and I know it is going to be for the better. But we have to help fight the fear of our patients and our colleagues today. We must not delay in resuming care for all our patients, as far more lives are at stake. Now is the time for all physicians to take this lead, not just CMA, but to all physicians to partner with their local hospitals and clinics to allay patients' fear of coming to our medical offices as their lives are at stake. By bringing back the practice of medicine, we'll bring back all of our lives, not just economically, but by restoring worldwide morale. It truly is a privilege to be a physician, to save lives, and to be your servant leader for our profession. I know it is hard now for all of us, but you must all survive as the world and your patients are depending on you. I leave you with the words of wisdom from Captain Miller, who died saving Private Ryan, saying to him, repay the favor by living a good life. So it is up to all of you to step up. It is time for us to all earn the privilege of being physicians by helping our patients overcome their fear with the help of medical science and your strong doctor-patient relationship with them, now more than ever. Thanks for being part of medicine, being part of organized medicine, and for saving lives. I'm proud to stand with you. Please join or continue to support your state medical societies. God bless our CMA and our profession in medicine. Thank you so much for the privilege of speaking to you tonight.
Thank you very much, Dr. Bretan, for really these very inspiring comments and all that you do for the state of healthcare in California. And indeed, as we are beginning to reopen, as we are beginning to change things to deliver the best healthcare to our patients. We really commend you. I just want to say on behalf of our organization that know that we are behind you. We appreciate all that you're doing, and please count on us if there's anything we can do to get behind you as we advocate for healthcare professionals so that we can best care for our patients and our communities. I'd like to invite Dr. Garni Barkhudarian, who is one of our board members, as well as on the committee of our continuing medical education. Dr. Barkhudarian is a neurosurgeon at the John Wayne Cancer Institute in Santa Monica. Dr. Barkhudarian will be moderating the question and answer session. Dr. Barkhudarian, if you can please take over from here. I'd like to really thank you again, Dr. Bretan, from our organization. And I hope that we will organize these types of communications and updates again soon.
Thank you, Dr. Tadilian, and much thanks to both of our physicians who gave excellent presentations today, Dr. Bretan and Dr. Kotikian. It was very informative, albeit very different topics. I think that they're very germane to our practices in general, and really appreciate your time this evening. I do remind anybody who is viewing this session to put their questions in the Q&A dialog box, and we'll address them as they come through. There are already a few questions, and Dr. Bretan, I'll start with you. I really appreciated your lecture, your presentation, and in particular, what did resonate with me was all of what was at the time pioneering work you did with telemedicine in your large territory that you covered that allowed you to expand access to your patients. And we here in Los Angeles in particular have been very happy with the telemedicine opportunities that have been afforded by CMS and by our governments to allow for still continuing our billing, but at the same time allowing for telemedicine to continue. And I was happy to hear that you expect this to stay. And I'd like to ask your opinion. You know, how is the CMA working with the AMA and other organizations to push this beyond the COVID crisis? As I can tell you, in Los Angeles, with its high traffic and congestion, it can take patients just a couple of hours to come to a doctor's visit, and that alone causes some stress and anxiety. And there's literature supporting that psychological and psychiatric visits have gone up in compliance as a result of telemedicine, which they hadn't before, primarily due to easier access to their physicians. So I just wanted to get your thoughts on that in the meantime.
Well, thank you very much. As I told you, beyond my farthest dreams, I was doing this to cover counties that did not have specialty care. But today, all of us have integrated this somewhere along the line. And I strongly encourage everybody. It is there's a simple format. There's so many different, including Zoom, to enable physician practices to see their patients. We are working very hard with AMA. We are congruent with them in our resolve to make all these changes permanent. It has become evident, as I had said, that this is not the last pandemic. It just scratches the surface. It is wonderful that we have this internet, and it's wonderful that the internet is here for us to have these meetings, for us to have communication, especially when we were sheltering at home. And now we have integrated it to safely see our patients. So I'm encouraged, and it's up to us, all of us right now, to integrate telemedicine the best we can. Any successes that we have now will be amplified with your patients in the future. So I encourage everything and everyone to utilize the CMA resources. I think California has always been in the forefront for technology. We're here with Silicon Valley. We're here with Facebook. We're here with all these high-tech companies right here in California. And now we have a governor who's aligned himself, and there's no difference between that and CMS. They have acknowledged that this is the way we're going to fight this virus, by having physicians contact their patients. So now is the time to do that. But as I already outlined, delay of diagnosis and care, I'm seeing patients just die at home of strokes and heart attacks. It's up to us to make sure that if you don't see your high-risk patients, to get them on the phone. Right now, telephonic services are being covered. So you could bridge that gap. I understand that the older population is not as sophisticated as the younger population, but you know what, it doesn't matter. The younger population has a different challenge. They don't want to talk to the doctors anyway. So I think this is the way that your doctor-patient relationship can grow. As you see me here, you get a gist of my passion. We should all share our passion with our patients. This technology is a chance for you to have an open insight to your heart and your practice and your caring, no different than inpatient or in-person visits completely. So I'm very encouraged, and I think we have an opportunity here, and we should all utilize it to the as far as we can.
Thank you very much. And I 100% agree. And that I do know there are a lot of practices that have taken this opportunity to reach out to their high-risk patients, and as a result are actually closing the loop on things that may not have been done in different circumstances. As a follow-up question, particularly for state of California, where many patients come to the state from out of state for higher levels of care or different levels of care, however they want to perceive this. And right now, the laws in the country are lenient enough in this crisis to allow for physicians to care across state lines. However, that is probably going to end when the COVID crisis ends. And I was wondering what your thoughts were and California's situation as a whole in joining the Interstate Medical Licensure Compact, as many states have. And this seems to be a barrier for our patients to have continuity of care after they've initialized care in our state and they go back to a different state, or they tend to live across state boundaries and want to have some mobility there.
Well, let me answer that question on two layers. Coverage in the hospital level is determined by medical staff bylaws. Coverage in individual practices are determined by state medical licensure laws. And you hit it right on the head. California is not as rural as other states, though we have a vast rural Central Valley and all the way up to Northern California, where they just don't have enough specialists. California is large enough. We have 110,000 physicians that we can care for our patients with telemedicine within the state borders. You're exactly right. It would be nice to have people outside of the state. But as you know, the requirements for the state of California and New York, I think, are one of the toughest places to practice. I'll give you insight that I don't think that the state medical board is going to relinquish that. They may relax it a little, but I think the standards for California are quite high, and they're coupled with our MICRA defense, which gives us some of the lowest liability insurances in the country. Those two vectors are probably not going to have California physician license be able to cover telemedicine open to the whole country. But it can be open to the whole state with 40 million patients and 110,000 doctors. I think we have, and as you know, we shipped out a fair amount of physicians to New York to help with the crisis. So I don't think it's going to hurt us in terms of coverage. I think that pack is better for the smaller states, but I don't think it's going to impact negatively California patients or California physicians.
Thank you. Transitioning based on what you were just saying with regards to where we are right now with the coronavirus, and there was a question by one of our constituents here. So I'm going to paraphrase his question. He basically is asking from a CMA perspective, are there guidelines or protocols issued regarding COVID-19 treatments? And probably more importantly, does the CMA play a role in monitoring how well we're following these in either with inpatient statuses or within practices outside of the hospital?
You know, the CDC guidelines enable local ordinances and local public health officers to be flexible. In the counties that I'm practicing in, Sonoma, Marin, and Santa Cruz, they're one of the lowest infection rates. They're not as high as Los Angeles. So there's a lot more flexibility in guidelines there. So, I think one of the most important things, and we released that with the governor, that we have to protect our public health officers. They were being harassed by different types of, and I have to say, these are political vectors to some extent. We're doctors. We do whatever science is, and understanding that there's a difference in demographics from one county to another. We have to support our public health officers, and we have to look at the data differently from county to county. Not all counties are the same. And we know California with 40 million people, we're as big as 10 or 15 states. And you could see the variability in one state versus another. So California has hot spots, and we have to deal with that. But I'm encouraged. I'm encouraged that if we stay with science, we stay with flexibility, we have a central warehouse or clearinghouse of information like cmadocs.org that we're constantly monitoring this. And believe me, I have my finger in the pulse. This is all I do. I have hundreds of emails every day. I am so privileged to be able to transmit that with my executive committee, and then release online advice directly to the governor, and to see that he responds very, very quickly. So we're working as one force, and I always envisioned that CMA, organized medicine, would be working hand in hand with the state government and federal government. We have a relationship with CMA, with our state government, obviously second to none. Obviously, we would like AMA and CMA to have that relationship with CMS. I think we do. We follow CDC. They're robust. They have a lot of information there, but we're ready. As you know, things change. They'll change tomorrow. I mean, they could change today and tomorrow. And then we're understanding more about the disease. I'm hopeful. They say that there's an increase in diseases, but hopefully if we don't have any new surges and we don't have an increase in the death rate, that is good news. That is good news. So I'm hopeful that perhaps we have gotten control of this so that we're not going to see a surge. Only time will tell us. And we have to monitor those hot areas throughout California and the United States to learn by that. But looking at everything over, and you could pay attention to Tony Fauci and the CDC. They're very cautious. I'm not trying to be cautious, but I'm an internal optimist at heart. And CMA will transmit the newest information concerning this and how we interpret that along with the governor and public health officers.
I appreciate that. And pretty much everything you said resonates with us here. We're a small organization, but we too follow that mantra that CMA has set forth. And I'm a member of CMA, and I'd encourage all of our Armenian Medical Society members to also be a CMA member, because it really is a powerful organization. I also would, and I've mentioned this before on this platform, as you said, we're the boots on the ground, we're the front line with our patients, and whether physicians, dentists, whatnot, we're the people that have to encourage our patients to practice the guidelines set forth by our medical leaders. I find that it's very easy for people to just blame the government for whatever, inaction, overaction, you name it. But bottom line is that, we do know that face masks work. People need to wear them and wear them properly. I find that a lot of people are using face shields instead of face masks, which is not the same. And I also find that people are becoming very, very relaxed with their social distancing, and it's becoming very evident as our bars and restaurants are opening up. So I'm not saying to close things down. What I'm saying is you got to be smart, and we got to keep following the rules, and that'll hopefully continue keeping this virus at bay, which it is showing to be a little bit more acquiescent, and hopefully we'll get a good handle on this. So really, it's up to us as physicians, as members of the societies, to push that message across to our patients. So Dr. Bretan, thank you so much. I do have a few questions for Dr. Kotikian, who has been waiting patiently as well. Dr. Kotikian, first of all, it's truly an honor to be moderating your session, considering we were roommates, not maybe over a decade ago now, almost 2 decades.
2 decades.
Yeah. So it's great to see how far we've come along.
Likewise.
A couple of questions. So number one, you had mentioned obviously the differential diagnosis of oral ulcers as including cancer, and squamous cell cancer is obviously very, very much the concerning one. One question though, have you seen any differences now with the HPV vaccine, and how is that playing a role with the way these cancers are developing? Are HPV-induced cancers behaving differently than, say, tobacco-induced cancers?
Very good question. So the HPV vaccine, I haven't read the article, but having talked to many head and neck surgeons, they've told me that they've seen actually a decrease in tonsillar cancers, but I have not seen it on paper because a lot of the tonsillar cancers, a good portion of them are related to HPV, but obviously they're associated with smoking as well. So there is word that they have seen a decrease in those HPV-related squamous cell cancers because of the vaccine, but I think time will tell.
I'm looking forward to that. I've heard that some people are recommending the HPV vaccine even after cancer is developed, and that seems to be somewhat helpful in the treatment of the cancers.
Yes, I've heard that as well.
Along those lines, you had mentioned risk factor. The number one risk factor for developing oral cancer is tobacco use.
Correct.
We're obviously in a state that has allowed medical marijuana, which is one of its forms is smoked marijuana. Has that been associated with oral cancers or other oral diseases?
Good question. I haven't seen literature on that. I would be happy. I will actually look it up. Haven't come across one. But my hunch is we will probably see an increase because of that as well in the near future.
I see.
Yeah.
And one last question I see here. So, in this COVID era that we're living in, obviously dental work is very aerosol generating, and one can even talk about the bone dust and other types of potential vectors for transmitting the virus. How, from a dental practice perspective, how have you seen people shifting? What are the new precautions people are taking to help mitigate viral spread within their patients, but also even with the caregivers and the team members as well?
So obviously for having the PPE, following the protocols, we stagger patients. So you don't have patients, close to each other. And after each room, everyone, including our staff and front desk, has N95s. We check everyone's temperature, including the staff and the doctors. Then we ask them a questionnaire the night before, if they've been exposed to anyone, if they've had any signs or symptoms, and on the day of. And we have them wait, actually not in the family room, we have them wait outside in their car or on the sidewalk, but obviously distancing themselves. Then we have them come in one at a time. And after each patient, we typically, in our office, in each room, we have microfilters. So after each patient leaves, we actually wipe everything down, following all the protocols from the CDA, and we don't allow patients to come in for at least 20 minutes into each room until the air has circulated and been filtered.
Thanks, Armand. So what are your thoughts? Are we at a point where dental practices can be at full steam and or oral surgery can be at full steam, and we're we're good to treat all of our dental issues?
That's a very good question. You know, we've been told to be cautious on what we do. Initially, we were just doing emergencies, but we're, you know, picking and choosing. There are some elective procedures, so we've put those on hold at the moment, but we're kind of picking and choosing and doing more of the urgent cases. But there are some that have been waiting, and because of certain procedures that need to be done, we've proceeded, being very cautious, but mostly there's patients who have emergencies, pain and abscess, or have facial fractures or lacerations.
Okay, good. And last question from our membership. Have you noticed any new oral issues or dental issues arising since the COVID crisis has begun?
Right. I haven't seen any. Again, we're very cautious who we allow to come in when we ask them those questionnaires. But there is literature that shows some of these patients actually have developed ulcers before they actually show all the signs and symptoms of COVID-19. And some will develop oral ulcers during when they're in full, you know, when they have all the full signs and symptoms. But there's also patients who develop vesicular bullous diseases as well. So it's ulcers and mostly vesicular bullous, but not too many, according to the literature. So time will tell, just like anything else.
Interesting. Yes, it seems like it's affecting every organ system that we have.
Right.
There or the other. All right. Well, I want to thank again Dr. Bretan and Dr. Kotikian for your great lectures. Really appreciate your time spending on a Monday evening with us, educating our membership. I do want to remind a few kind of housekeeping reminders. So first of all, we have a webinar tomorrow with TAS and estate planning, discussing implications of COVID-19 on one's estate. Also, I want to remind everybody that we have begun planning and preparations for our annual Las Vegas event, which will be a CME event, as well as a networking event, which will be on September 11th through 13th at Caesar's Palace. This is for anybody who has the risk tolerance to go and enjoy themselves. And obviously we'll be taking all precautions necessary, including outdoor lectures and venues to limit transmission of disease. We will have more information on that over the next week or so, but I thought I'd let that be announced. And with that, again, I'd like to thank Hasmik Keribarian, Viken Sepilian, Dr. Kotikian, Dr. Bretan for your time, and we'll end the session there. Thank you very much.
Thank you.